Okay, now we're back. So hopefully while we were gone, you didn't just go eat a donut, but you paid attention to what the hell I was saying, because I've already equipped you with picture number 1 in the NCLEX coach page. And picture number 1 is what I showed you earlier, and you were supposed to see if you could do what I instructed you to do, which is look at it. Just look at it. See if it looks regular. If it's not, it's AFib. You were supposed to count the R's. Prayerfully, you counted the R's, you came up with your rate, and then you were supposed to look at that P wave that I showed you is always predictably right before the QRS. If you did that and you figured out the rate, and you know that that rate on that one strip, number 1, was 80, then it's not a bradycardia and it's not tachycardia. But let's pretend that it is. If it is a bradycardia, the most important thing you can do as a nurse taking a test and dealing with a real patient is ask the patient about symptoms. You have to know your cardiac symptoms when it comes to EKGs. Your cardiac symptoms when it comes to EKGs include dizziness, syncope. Those are probably the number 1 and 2, well, they're the same thing, but somewhat similar, right? Not exactly the same, but those are the most important ones. So syncope, dizziness, low blood pressure, chest pain, shortness of breath, fatigue. Boom, you better know that. Because if they're symptomatic, that's when we care. And if we care and they're symptomatic and the heart rate is less than 60, consider atropine, or if they're unstable and that didn't work, we may have to do some transcutaneous pacing. Maintenance for that patient, which means next week, next month, to stop it, may need to be a pacemaker. Know your bradycardia. It's really an easy strip to know. It's not that hard. It's actually pretty reasonable. No sweat off your brow. Now let's move on. Let's look at tachycardia. Tachycardia, on the other hand, is going to be where the heart rate is greater than 100. Now, it's interesting because I learned in school back in the 80s. Yeah, I'm an old ass, okay? But I learned back in school that it was greater than 90, so stay tuned to that. But for your purposes on this test and in real life, it's going to be greater than 100. It's a little interesting what we do with tachycardia, because with tachycardia, a heart rate greater than 100, we identify it on the EKG that it is indeed greater than 100, and then we treat the cause. Well, what could be the cause? Oh, you better know. It could be an infection, which could lead to sepsis. It could be an outright hemorrhage, which is horrible, right? You know, like a post-op patient. And that patient could be going into shock. And all of those could give you tachycardia. It could be your girl. Woohoo! I have Graves' disease. I was real tachycardic before I got diagnosed. It could be anything. It could be anxiety. It could be just about anything. But here's where we draw the line with tachycardia. We draw the line with tachycardia if the rate is greater than 150. Because if the rate is greater than 150, then we've moved into a higher level. This is called supraventricular tachycardia, and it's serious shit. And you've got to treat it with IV push, very fast, rapid IV push, adenosine. They may need a cardiac ablation scheduled, sort of like the bradycardia patient for maintenance needed a pacemaker. For maintenance, they may need a cardiac ablation. Now, I just want to say something about pushing IV anything rapidly. There's no way in hell you're going to take your behind to that hospital or that long-term care facility and push anything rapidly, except for adenosine and epi. Everything else must be pushed over 2 to 5 minutes, or you're going to cause really horrifying low blood pressure, dizziness, and fainting. So this is one of our exceptions where you can push it super fast and not even care, okay? In fact, you have to make it work. Now, adenosine is interesting. We'll talk about that later. Last but never least, remember that P wave? Oh, you thought I forgot? Oh, hell no. The P wave. You had to find a P wave. You had to make sure it was immediately right next to, close up, close and personal to the QRS. And if it wasn't up close and personal and there was a pause, it was heart block. Now, you're going to go to that strip. Strip number 1 is the one we already covered. You're going to strip number 2 and you're going to look at that strip because I'll be back with more. Stay tuned.